And so you have to be flexible and adapt. The strategies and the techniques that I learned as a fellow 8 years ago aren't necessarily the same strategies and techniques that I'm applying today as a pediatric surgeon. So that evolution is really important. And so I think that gets back to that word practice.
Rising above the buzz of ultrasonic cleaners and the clanking of stainless steel are the ideas and voices that are changing an industry. You're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are improving our sterile processing world. Each week, we speak with frontline technicians, CEOs, engineers, and entrepreneurs with a common goal: to help you fight dirty, every instrument, every time. Whether you're tuning in for education or inspiration, we're glad you did. Now turn on those washers and turn up the volume. It's time to go beyond clean.
What's up, Sterile Processing Universe? My name is Hank Balch, and this is...
Hi, I'm Bobby Parker. What's up, Hank?
And on today's episode, we're going to be talking to Dr. Erik Pearson, pediatric surgeon at Pediatric Surgery Associates in Las Vegas and the founder of Citizen Surgeon, about the practice of medicine, learning from the very first cut. We're going to dive in to what it means to learn not only surgery, but surgical instruments and how that impacts all the critical work that we do in SPD, the patient, back around the cycle again once we get those instruments back to our team. So, Bobby, a lot of great topics on the radar today.
Yeah, I'm looking forward to talking about the education piece of it. We spend a lot of time thinking about training and sterile processing, how to take that person who's coming in off the street, who's only had to spell OR once, to being an expert in thousands of surgical instruments, and how magnified that has to be for somebody who's slowly moving from medical school into being that residing physician who is maybe training a resident of their own. And it sounds like we've got the right guest to talk about that journey today.
All right, well, hang with us. We'll be right back in studio with Dr. Erik Pearson.
From the studios of Healthcare HQ, you're listening to Beyond Clean, the global voice of sterile processing.
Clean Freaks, we are in studio today, back in studio actually for the second round with Dr. Erik Pearson, the pediatric surgeon from Pediatric Surgery Associates in Las Vegas and the founder of Citizen Surgeon. Erik, welcome back to the show today.
Hey, all right. Thanks so much, Hank. It's great to be here.
I know we were talking just before we started recording that the first time we had you on, a really powerful interview on pediatric surgery itself and all the nuances. What makes that different from the everyday, not the everyday, I guess, the other service lines within surgery and just the smallness of the patients? And I think in that episode, I shared that I worked in a pediatric trauma facility for a while, and just remember the very first time that I saw the baby stretcher, and it was like kind of looked like a baby bed, with like walls on it and stuff. And it was in the elevator, and I was not prepared for it. And it was just an empty stretcher, right? Like no patient or anything in there, but it was like the little baby surgery bed thing. And I was like, man.
Yeah, that's right.
That's what's going on here.
I remember the first time that I operated in one of those isolates, and just folding those little walls down, and that turned into the operating room at the bedside. And, to your point, I feel like as a pediatric surgeon that there's no greater privilege than taking care of somebody else's child. And so I certainly feel blessed to do what I do every day. It's just an amazing job, has a ton of meaning. And when I go home at night, I can look in the mirror and say, I did something good today.
And if people feel like they recognize your name, I know they can't see you because we're just audio, but if they feel like they recognize your name or even your voice, they may know you from a lot of content that you got out there on LinkedIn. You're very active on that network, adding a lot of value to the space. But you've also got that Citizen Surgeon channel on YouTube. Can you give us a little background about what that is?
Yeah. Well, thanks for mentioning that. I really enjoy LinkedIn. It allows me to interact not only with other doctors, but everybody in and outside of healthcare that has an opinion or an experience. So I found LinkedIn to be just an incredible channel to start discussions and keep discussions ongoing. For Citizen Surgeon, it started as a blog when I was a fellow and just getting some ideas, the challenges of being a resident, the challenges of being a fellow. And then during the COVID pandemic, when students had lost the ability to go grand rounds and get education, I said, well, I can just throw up a green screen in my garage and give some talks. And so I did that. And then I found that, it wasn't just medical students and residents and even non-healthcare people that I was serving in the States, but all over the world. So I had people reaching out to me from India and Pakistan and all over Africa, South America. And, hey, we love your videos. We don't get this type of content. So then that inspired me to just keep going and provide a free resource for people to get some surgical education and medical education content. So it's one of my passion projects, and I wish I could be a little bit more consistent. But when I have the time and I can sit down and put a video together, you can put it out there and it's evergreen. So that's what I love about that.
That's great. Yeah. We were talking offline too before we started of just the lack of time to do your clinical day job and do all the other clinical content, that would add value outside of that. And it's clearly a passion project because you don't have more time than anybody else does. So you're making time to add that value for all kinds of folks that you'll never meet. And it's that value piece. It's the education piece actually that we brought you back in studio to talk about on this episode, the concept of the practice of medicine, which assumes learning, right? You're practicing because you're wanting to get better. In order to do that, obviously you need education to learn from. But talk us through just that phrase. I think if you've never sat down and really thought about what that means, you may not understand the true value or implications of it when we say that we're practicing medicine. But yeah, how do you want to kind of start that conversation?
Yeah, first is that practice is a very intentional word. And it doesn't necessarily mean practicing on patients, but the word's been used since the Middle Ages and then through the Renaissance. And in modern times, the practice of medicine really means the commitment to the idea that medicine is dynamic. And you really never achieve expert status. You're always learning, you're always improving, and the environment that you're working in is always changing. And no two patients are the same. And so I remember I was on a vacation one time, and it was funny. I was standing in line to go into the theater, and there were two doctors chatting behind me, and I might have been 15 years old. And I said to them, I heard them talking about their practice. And I said, well, how long have you been practicing? And they said, well, it's hardly practicing anymore. And
Dr. Jones.
That's right. But it stuck with me, but the essence is when you're making that transition from medical student to resident, you are now taking theory and applying it to real world experience. And that is what the practice of medicine is. It's taking theory and then applying it to solve a real world problem. And for me as a surgeon, the practice of medicine to me means that I'm going to continue to improve. With respect to instrumentation, there's always new instrumentation available. And as a surgeon, I provide mechanical solutions to medical problems. All right. It doesn't matter if I'm taking out a cancer or if I'm fixing a hernia or if I'm building a new esophagus or building a new rectum or whatever it is, I'm providing a mechanical solution to a medical problem. And as innovators come up with new instrumentation and new ways to solve those problems, I have to be flexible in my practice to apply those new solutions to the problems, and in more cases than not, that's going to be a better outcome for the patient and more efficient surgery.
That reality has never been more apparent to me than when I started in sterile processing and got a good idea of what a total joint replacement was. I think I just had this fantasized picture of what was going on in that room, but you look at the instruments and, without knowing the names of these instruments, you've got hammers and chisels in there, and you look at the picture of a completed one, it's like they just replaced their whole joint with a bunch of metal, and it works. It's wild to think about.
And all of those little tools are so specific. It's really remarkable. To this point, I correct a problem called pectus excavatum, and it's where we have funneling of the chest. And so sometimes that can compress the heart. It can decrease space in the chest so the lungs can't expand. And if children need to have this repaired, we put instrumentation into the chest to fix that. Well, early in 2024, a company came out with new bars that are made of titanium, so they're non-allergenic and they connect to each other. And it was a total paradigm shift in how I can approach correcting this problem. And so, I went to a course, I learned about these bars, and I said to myself, wow, there's no better way to fix this. So, and that instrumentation is very specific. The rep flies up from Phoenix to join me for these cases and brings all of the instrumentation that we need. And much like you're commenting on total joint, these are very specific tools, but it changes. And so you have to be flexible and adapt. The strategies and the techniques that I learned as a fellow 8 years ago aren't necessarily the same strategies and techniques that I'm applying today as a pediatric surgeon. So that evolution is really important. And so I think that gets back to that word practice.
For sure. And that gets at what it is that we're wanting to unpack today, because I can't think of any other career or position where, as recipients of that service, we value experience more, right? Nobody wants to be patient number one for a brand new surgeon, right? We want somebody who has experience, who has kept up with the latest technology, who's implementing the very best care plan that we possibly could. But there's also that reality of that transition from theory into practice as you're learning. So I'm curious, could you give us a little bit of a picture of what that was like for you, what maybe your first live patient was like in surgery, kind of how you learned and how you felt prepared for that moment, transitioning from theory into practice?
Yeah, when I reflect back, the first case I did as an attending, so if we could jump all the way from, we could say the first live patient that I put my hands on as a medical student versus an attending it, it's much different. So as a surgical attending, I remember I got that first consult. So this was in August, 8 years ago, and it was for appendicitis. And I had taken out probably almost maybe close to 500 or so appendixes during a fellowship and residency. And I felt pretty comfortable what I was going to do. And I went to the operating room and I didn't have my preference cards set yet. And so I said, well, I'll take the VersaStep radially expanding trocars, and then we'll take this stapler. And I remember the scrub tech that I was working with said, well, we don't have those trocars and we don't have that stapler. And
you're like, this isn't starting good.
I was like, okay, all right. So end up using OptiView trocars and end up using a little different stapler. But that experience as the first time really demonstrated to me that at the end of the day, you can have an idea and a plan and have all these steps in your mind, but you really have to be able to adapt and realize that surgery is like a story, and a story has a beginning and a middle and an end. And when I'm teaching the residents, I'll say, the beginning of the story is choosing your instrumentation and setting up the patient and where your incisions are going to be. The middle part of the story is actually accomplishing the goal. And then at the end, it's, how do you close up, what dressing is going to use, etc. But in that experience for me, I said, okay, these are not the instruments that I've used every day, but I can still adapt and safely use different instrumentation to accomplish the same goal. And that happens from time to time. Hey, we're doing this operation. Sorry, that instrument's broke or we don't have it, And so how are we going to adapt? We still have to solve this problem. But that was my first experience. So I remember having a little butterflies, but before I actually did that operation, of course, I used the stapler and made sure that I was comfortable using it. And then, of course, the trocars were quite easy because that's quite transferable. But I made sure I could use, just as a disclaimer, I made sure I was comfortable with everything before I did that operation.
Yeah. Just this morning on LinkedIn, I posted a quote from a guy I like to read a lot of named Chesterton, G.K. Chesterton. And he's got a little quip that says, the essence of art is limitation. And even as you were describing surgery, right, in this story, it's not like you sit down and write any story you want with any tools you want, any characters you want. You're given a patient that you don't get to pick anything about that patient, right? Like what their background, what their medical background is, what their anatomy is. You get to pick that. And sometimes you don't get to pick the tools you write the story with, your story about the preference card and everything else. And so you're kind of given all this in the moment and then said, now write me the best possible story that you can and then give me the outcome. I mean, it's a beautiful challenge, but I mean, every single day is different, to your point.
Every day is different. Every patient's different. Yeah. And then it's not necessarily, I try not to think of operations in steps, but just think about it in this progression and then having different plans. What if plan A doesn't work or plan B doesn't work, plan C, and then ultimately when things happen dynamically, you've already thought about all of these things. And that's why preparation is so important. Whether you're attending 8 years in like myself, I still prepare for every case and look at the imaging and think about how I'm going to accomplish the goal, or you're a intern scrubbing in for your first hernia. Mm-hmm. I laugh because I'm thinking about the first hernia that I did with as an intern in general surgery, but
yeah,
all good memories.
So let's talk about that instrument piece though, because this is something in sterile processing that we have experience on one side of that. We know that surgeons train with particular instruments, like depending on like where they're training or who they're training with. And then they get out into the field, different hospitals. And, many times they're bringing those instrument preferences or that training style with them. And I'm just curious, like, what that experience is. Maybe what that experience was for you. Like, do you, because you train with particular instruments and approaches, is that sticking with you your whole life? It's changing, obviously, as technology changes, you alluded to. But yeah, kind of talk me through those implications.
It's interesting because I, as a resident and as a surgical trainee, I did a lot of watching and I did a lot of observing. And when I say that, what I mean is watching how different surgeons reacted when things didn't go their way or when an instrument wasn't available. And some surgeons react with a very adaptable mindset. Okay, well, what else do you got? Okay, let's use that one. That needle driver, that laparoscopic needle driver is not available. Okay, no problem. Let's use this one. Versus, what do you mean that's not available? Get it, find it. The temperament and the environment changes in a very negative way for option B. So observing that as a resident told me as a surgeon, number one, go in to the operating room and have a discussion with the scrub tech and the circulating nurse before the operation to find out what instrumentation we're using today.
That's a novel idea, but that sounds like a very good recommendation.
But there are surgeons that just show up and expect everything in the tray to be available and perfect. And that's just not reality. even where I work every day, sometimes we have laparoscopic liver retractors for little neonatal surgeries. And there's times when they're broken and we have to use different liver retractors. And if I'm finding that out in the moment, it can increase my anxiety. But if I have a discussion with the scrub tech 15 minutes before the operation, I say, okay, what do we got today? What are we using? All right, this looks perfect. Oh, we don't have that. Now I can get my mindset different with that other piece of equipment, or I can take that, feel that, use that in a peel pack or something. And so that part is really was important in my observations as trainee, is be adaptable and be prepared, because it's just not always going to be perfect. And as far as like the way that I use instruments and my preferences, I certainly go back to my training. So because as a surgical trainee, I'm going to train with 15 different surgeons or 20 different surgeons. And I'm going to look at one surgeon. I'm going to say, man, the way that they use that instrument, or they use this particular instrument in a different way, I'm going to write that down because that was really slick. And so the neat thing about being a surgical trainee is that if you're paying attention, you get to pick up the best of that variety. If you're not paying attention, then you don't. And I'll tell you that the scrub techs are so key in a trainee's development, because, I remember, trying to be that trainee that would get into the operating room early and talk with the tech and find out, hey, can I get my gloves, or can I get an extra gown, or can I get anything for you? And then those scrub techs would give me, a wink or a nod that I was doing the right thing, or they'd shake their head and say, Erik, you're pushing too hard there. So I think that part of being a trainee and developing good relationships with the operating room staff and the operating room team is incredibly important.
Yeah. Yeah. What is your thoughts on the training versus that comfort level with the instruments, right? Like you mentioned a great takeaway. If you're paying attention in your training process, you're going to glean the best practices or the best approaches, like across the board. Is that true for instrumentation as well? Like, I'm assuming you're not trained to only do it a certain way with only certain instruments, but that adaptability piece, does that come in just when things go wrong, like when you have to adapt, or is that kind of trained into the process of, hey, if you don't have the liver retractor, these are the 3 other things that you can use? Talk us through that, and then like how long it takes you to get comfortable, with that. Because I know that you mentioned like now you're kind of like, okay, if we don't have that, yeah, like what else we have, let's go.
Well, to your point, and I think it's important, is when you're starting out, and I feel like this is in anything in life, with you're cooking an omelet, or you're doing surgery. I don't want to say that they're equivalent, but in a way, learning any process is the same. And so when you're starting out, it's very, very specific that I'm comfortable with this needle driver. I'm comfortable with these pickups. I'm comfortable with these trocars. I'm comfortable with this Verus needle, or whatever it is. And then when you develop a real confidence with those tools, you realize that they're just tools for the technique. And then I think you become more adaptable and more flexible. I think there's some rigidity early in the process because you're focused on the fact that you want to do this operation perfectly for this patient for the very best outcome. And all that you know is how to use these instruments to do that particular surgery. But over time, as a surgeon, what I've realized is, well, I can now use a huge variety of instruments to achieve the same goal because my technique is not as much instrument dependent. And I don't know if that's particularly clear, but, I can watch, Jacques Pepin make a French omelet with a fork. And, I need like a nonstick pan and a special spatula and everything, everything perfect. And I still burn the dang thing. So I don't have that technique for French omelets because I'm not Jacques Pepin. But in surgery, I feel like I can use maybe not a fork, but I could use a lot of different instruments to achieve the same outcome because my technique is not as instrument dependent now for most things. For things like pectus excavatum or things, there are very specific surgeries. So, for example, in neonatal surgery like pyloric stenosis, where we split the pylorus, there's very specific instrumentation using a pyloric spreader to split that muscle. I need to have that instrument. And if I don't, I can still get through the operation, but it's not as smooth and safe. So that's one thing in the preparation phase. I always talk with the techs, hey, do we have the pyloric spreader? Do we have the click line tray? Is everything working properly before we bring the patient in the room?
That's one aspect that I want to make sure that we bring out before we close the conversation is what the impact is to the patient. Or you mentioned, just the anxiety of the moment. You can't always be prepared for all the problems that are going to arise during surgery. Maybe the instrument's discovered faulty during the procedure or something like that. And we can't just give you a spoon and a spatula and say, figure it out. Like sometimes there are instruments that we can't so easily sub out. So can you walk us through what that impact might be to a patient or even just to a surgeon? You referenced anxiety earlier whenever things go awry and it's not something that we can easily plan for or substitute out.
It's a great question because I think that there are certainly operations, and every surgeon could tell you in their specialty what they are, but there are operations where we have go, no go for launch when it comes to an instrument. For instance, if I'm doing the pectus excavatum, if we don't have the bars, and we don't have the right connectors, and we don't have the right screwdriver to put the connectors on the bars, then we can't do the operation and the patient can't go to sleep because there's just no substitute. And so as the surgeon, I'll go in and talk with the techs, while the patient is clearly in pre-op and make sure that we have everything and everything is dialed. And that's very specific. Now, there are other operations where, if we don't have a stapler or or we don't have a staple load or for taking out an appendix, well, I can still get through that operation. I could still use a vessel loop to take the appendix. I could still, if we didn't have a ligature device or harmonic scalpel, I would usually use a hook electrocautery to take the vessel. So there's operations that are much more adaptable. Inguinal hernia repairs, I really just need a scalpel and some simple dissecting equipment if I'm doing open, and laparoscopically, I just need simple instrumentation there. So there are operations that we can do, as you said, the spoon and spatula approach. But then there are other operations that are very much like go, no go, green light, red light, if we don't have specific things. And as the surgeon, it's really important to work with the scrub tech. And as the scrub tech, it's really important to work with SPD to know that stuff is or is not available, hopefully the day before, but really early that morning of, so that we don't get into a situation where a patient is brought back, put to sleep, and then we make some go, no go discovery. That's never happened to me, but it's certainly something that is always on my mind in those specific operations. And we have a great team that I operate with. And so having that team approach, they might say, hey, Dr. Pearson, we don't have that. And then I'll say, okay, then we're done. We're done today. And we'll do this another day.
So, Doc, before we wrap up here, you gave a great explanation on the impact of those surgical techs early on in your surgeon learning career and that learning curve, right, and the impact that can have. And still today, I'm sure, right, they're still teaching you.
Absolutely.
Because our audience is primarily sterile processing, I'm wondering if we could close with the kinds of information or insight that a sterile processing department could proactively attempt to provide to these residents. Because as you mentioned, you're just naturally attuned to soaking up information, but I know like there's some folks that are maybe not that nuanced on, gleaning, but they would take it. They would learn if someone kind of brought it to them and said, hey, like, you should really be asking these questions, or you should be looking at these challenges. Like, what could SPD add in to this journey of surgical excellence for the surgeon early on in that career that would make the biggest difference?
Yeah. I would love to see a better relationship, or a more engaged relationship between surgical trainees and SPD, because in SPD, in the sterile processing department, there is a whole room of instrumentation. And when you're a trainee, magically this tray appears, and that's all there is. That's not all there is, right? There's a whole room of stuff that's being prepared and trays that are being built. And so, one thing is, I would like to see surgical trainees spend time in SPD, not only to understand what's available, but to understand what the SPD team goes through to make these trays. Now, I've gone back there as a surgical attending, but I said to myself early on, like, man, I should have spent more time as a resident with SPD to understand how these trays are made, what instrumentation's available. So that's what I think a resident can do, is be more intentional about their education by spending time in SPD. What could SPD do? I think it's being very clear on the trays when something isn't in there, and I think that's really important, or when there's a change, because, it's one thing that I find interesting, and it's a little subtle thing, but with adds and forceps, there are adds and forceps that are very, very fine, and there are adds and forceps that are really heavy. Like, I was picking up a T-bone with them or something. And it's funny because sometimes there'll be an inconsistency in the forceps that are just delivered. And so, I'll be doing a real delicate neonatal case, and I'll have like the orthopedic adsense. I'm like, dang, like, the last case we were doing on a 17-year-old, it would have been great.
I know. I was like, the baby's
to
not
have
that
those. It's one of these things where it's not always possible, but I think if there's changes in instrumentation, a needle driver is not necessarily a needle driver. I think that's an important aspect, is to know exactly what's in the tray, what's not in the tray, and what's been changed. So that's
I love
the other side of it.
I love, that change management piece. I think that is a massive gap, and the nuances between instrument styles and your product numbers and everything else. Like, I think, especially for what you do in the pediatric service line, right? I mean, the implications are even larger, right?
Well, and I would say one other thing that's kind of funny is people, a lot of techs. So if I work with a tech that doesn't work with me often, or with any of the pediatric surgeons, they assume that pediatric surgeons, since we're operating on babies, we like to have the really tiny needle drivers.
Okay.
That's not true. That's not true. We like to have regularly sized needle drivers. Our hands are not any smaller than other people's hands. Regularly sized needle drivers.
So it's not babies doing surgery on babies. It's
That's right.
Regular sized humans. Okay.
Yeah.
All right, Dr. Pearson, really good to have you back. Really excited to tell this training story in light of SPD, right? The implications that we have on these
Absolutely.
new surgeons coming into the industry. And like Bobby said early on, we all want our surgeons to go through this process successfully, right? To get to that point to where they can confidently step up to the patient and know no matter what happens that they're going to have a plan in place and they're going to have instruments in place to get this job done. So great conversation today. Thank you for all the contributions that you're making in the industry through your LinkedIn content, through your Citizen Surgeon channel, but obviously what you do every single day in the OR with your patients out there in Las Vegas. Just really appreciate your time.
All right, Bob and Hank, thanks so much for having me on here. I always love our conversations. And thank you for all the kind words.
All right. right, that was Dr. Erik Pearson, pediatric surgeon at Pediatric Surgery Associates in Las Vegas, Nevada, and the founder of Citizen Surgeon on YouTube. Bobby, really good interview today, lots of value, and we even talked a little bit just as we wrap there with the doctor that, he trains residents and he's implementing exactly what we're talking about today and getting those residents down into SPD to get some of that exposure to build these bridges so that the comfort level is not just with the instruments themselves, but also with the people behind the scenes that are processing, inspecting, and sterilizing them. You can't go wrong with building those types of bridges.
Yeah, I appreciated that closing question that you asked, Hank. And it goes both ways, right? I've actually participated in giving some sterile processing education to some residents. We had a class of them coming through the hospital where I was managing the SPD. And we had over 2 days, I think, about 10 different residents come spend a few hours with us. And we just rotated them through. By the end of that, my team was coming to me and asking, please, no more surgical residents. Because
too many.
Well, it's an investment on our end as well. Yeah. And these were people who were being trained in Louisville, but they weren't going to be surgeons at the hospital where we were. So it felt like we were making an impact for somebody out there, but weren't feeling the benefits of it in our own department. And so it's definitely an investment, and it takes that collaborative culture between OR and SPD to really go at that. So something that we would strongly encourage you to try to implement and get involved with your OR educator and making that an important part of both the surge tech and OR nurse and surgical resident training. But it takes some planning and some doing for sure. Yeah,
that's a really important practical call out is we sit here and, lots of people have talked about this, right? But like we all advocate for, hey, we need people to come down in SPD, want the surgeons to come down, want the nurses to come down, want the admin to come down. Well, every time someone comes down, that is interrupting the workflow of your SPD. You need somebody there to add value. Like, you don't want them to just come around and stand in the corner because they're not necessarily going to know what's going on. So you need a body with them at least explaining if they're going to get hands on. That's even more interruption. And then if we are already short staffing, it can be very overwhelming for the leader, the department, and whatnot. So it is we got to bring this from conceptually, hey, this is a great idea, to, hey, practically, how do we make sure that's a great experience for SPD and for anybody else that we're inviting in? So, that's a challenge. It's probably worth talking about on another episode or two down the line. That's going to do it for today's show. Hope you're enjoying season 27 of Planet Surgery. We've got one more fantastic episode coming down the pipeline to close out this season, but we're going to wrap it here and remind you, like we do each and every week on Beyond Clean, to keep fighting dirty.
Thank you for listening to this week's episode of Beyond Clean. As a reminder, you can help support us by subscribing to Beyond Clean on your favorite podcast app, or by downloading the smartphone app on iPhone or Android. Simply search for Beyond Clean in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@beyondclean.net. We look forward to hearing from you.